Hello, my name's Ian McCollum. This is just a short video on the calcineurin inhibitors, tacrolimus and pimecrolimus. These drugs are available in topical forms, and we primarily come across them in the management of atopic dermatitis. And the reason that they're used in atopic dermatitis is that they are anti-inflammatory, but they're not a topical steroid. So they don't have the side effects of topical steroids, or at least if strong topical steroids are used in the face and overused for a period of time, you can get thinning of the skin, you can get perioral dermatitis and steroid-induced rosacea. And of course, in certain flexural areas, you can get stretch marks and the like. So these two topical preparations are really quite useful. They act on an enzyme that's involved in the attraction of T cells into inflammatory lesions and an activation of those T cells into the formation of cytokines. And so when this drug's applied, it stops these things happening. So you can see there that it's used in a variety of other disorders. And many of them, in fact, are autoimmune, like lichen planus, like vitiligo, and even lichen sclerosis. Now, certainly these are areas where strong topical steroids are sometimes initially used, and certainly strong topical steroids are useful in lichen planus and in lichen sclerosis. Not quite so useful in vitiligo. And also in areas, say, around the eye, where you may have vitiligo, strong topical steroids can induce glaucoma, and so topical tacrolimus or topical pimecrolimus are better therapies. Tacrolimus is more effective than pimecrolimus, slightly more irritating when applied to the skin as well. These two compounds are macrolides, and they're produced from soil bacteria, Streptomyces. Tacrolimus itself can also be used intravenously after liver or kidney transplantation, and orally. And there are many patients with transplants who take this as one of their primary immunosuppressive drugs. Here in Australia, we don't have tacrolimus available. Overseas, it's under the trade name Protopic. But we can get it compounded here in Australia. And it's usually in a 0.1% preparation. Some of the other disorders that it can be used for are interesting. Say psoriasis. And the types of psoriasis where it's mainly used are facial, inverse, and genital. And of course, these are areas where some of the stronger topical steroids may cause problems. So remember, it's used in psoriasis, facial, inverse, and genital. In lupus, it's particularly effective for discoid lupus, and some studies have shown that it's as effective as one of our strong topical steroids, like 0.05% betamethasone. Interestingly, it's also useful in seborrheic dermatitis and rosacea, and the perioral dermatitis variant of rosacea. Again, it's mainly its anti-inflammatory action with sebderm. It's not going to reduce the concentration of the yeast organism that's involved in seborrheic dermatitis, and it's not going to reduce the concentration of Demodex that's involved in rosacea. Other studies have shown it useful in pyoderma gangrenosum and in the condition granuloma faciale. I've used it a reasonable bit in frontal fibrosing alopecia, and my personal experience is that it does appear to be effective in suppressing the process. Of course, you don't get hair regrowth in this condition because it's a scarring alopecia. But I must admit, I've found it quite useful. I noted tonight there were another study, though, that had used it, and they felt that it didn't offer any benefits above placebo. So You just have to decide which way you're going to go. There isn't a lot that can be used in treating this condition, frontal fibrosing alopecia, anyway. Sometimes it's used in combination with hydroxychloroquine. There was this issue of malignancy with both pimecrolimus and tacrolimus, and this was in relation to lymphomas, but also, if used topically, in relation to precipitating squamous cell carcinoma. And this was most likely to occur if you were treating vulval or oral lichen planus, or perhaps lichen sclerosus. Now, the incidence of this is very, very low. But the FDA in the United States did put what's called a black label listing on pimecrolimus in these circumstances. And some of my pediatric colleagues have seen SCC induced from the use of this in treating lichen sclerosus. I'd have to say I've seen a lot of lichen sclerosus in my time, but I've yet to see, no, that's a lie, I've seen one SCC develop in a patient with long-standing and improperly treated lichen sclerosus. So I don't think the malignancy risk is a major factor here. It's certainly not one I'd be bringing up in great detail with patients. Pimecrolimus is similar to tacrolimus. We have it available here in Australia. It's supposed to be avoided in children under 2 years of age, but we use it to prevent the flares of atopic dermatitis. And I'm afraid that there are many children under 2 years of age who do have flaring of atopic dermatitis, where pimecrolimus is quite useful. I think it's just that it hasn't been studied in children under that age. So if you are going to be using it in children under that age, it's a little bit off-label. I find both these preparations are quite simple to use topically. As I say, tacrolimus does cause a bit of irritation, say, around the eyes and sometimes on some mucosal surfaces, because it can be used on the oral lesions of lichen planus as well. But generally, they're really tolerated very well. There's not a lot of other information I can give you in this. It's, when new preparations that are anti-inflammatory come out like this, they tend to be thrown at a whole variety of skin diseases just to see what effect they may have. It's also been trialed, say, in morphea and scleroderma, which is another type of autoimmune disease. I don't have that up there. I don't think there are many cases where, in fact, it has been used. But even in other unusual things like granulomalare, necrobiosis lipoidica, Haley disease, you can consider why it might be used in some of those. If there's a strong inflammatory component, it may well reduce that, but it still doesn't get to the root cause of some of those disorders. But in many ways, that's the same way that topical steroids work. So we're just using it as a proxy for topical steroids in many of those conditions. Another condition that I haven't mentioned there that is akin to atopic dermatitis is Netherton's syndrome. Netherton's syndrome is where they have the bamboo hair, they have a rash that's like atopic dermatitis, but they have a double-edged scale to the annular lesions in Netherton's syndrome. And apparently tacrolimus was quite useful in this, although it appeared as if the drug was absorbed a lot more than usual. But though the levels that were found in these patients in the blood were quite high, none of them had any systemic signs of toxicity. So it's effective in Netherton syndrome as well. The only other adverse effects that are associated with tacrolimus are some enhanced facial flushing after alcohol, and the occasional patient can get a rosacea like dermatitis. The other thing that can occur is reactivation of human papillomavirus infection. I don't know about any reactivation of herpes, but certainly the papillomavirus. So that's a quick overview of tacrolimus and pimecrolimus and their use in some of these other conditions in dermatology. Thank you very much.